So the combination of a proteasome inhibitor and an immunomodulatory drug is becoming the standard initial therapy for patients with myeloma. Bortezomib in combination with lenalidomide has shown improved overall survival compared to just lenalidomide and dexamethasone in the SWOG study. The Ixazomib is the first oral proteasome inhibitor that has entered the clinic. The Ixazomib has been combined with lenalidomide and dexamethasone in the relapse setting, and a phase 3 trial showed improvement in progression-free survival for that combination, leading to its approval. This was the first study that was done looking at the combination of Ixazomib, lenalidomide, dexamethasone in the newly diagnosed setting. So it was a phase 1-2 study. The initial phase 1 portion looked at increasing doses of Ixazomib in combination with standard dosing of lenalidomide and dexamethasone. And once we reached the recommended phase 2 dose, we enrolled an additional 45 patients at the recommended phase 2 dose level. So overall, the study enrolled 65 patients, 15 in the phase 1 portion. The focus of the current presentation is on those patients who actually did not go to stem cell transplant. Now, the study is designed in such a way that patients could collect stem cells after 3 cycles of induction therapy and then go to stem cell transplant after 6 cycles if they wanted to. So we published the initial results of this study for the overall cohort of 65 and demonstrated that the combination has a higher overall response rate. This analysis was looking at just those 42 patients who actually continued on therapy without going to a stem cell transplant. That also included 25 patients who received maintenance therapy with Ixazomib as a single agent after the 12 cycles of induction therapy. So the takeaway points from the current analysis are: one, the combination is very safe and effective. The overall response rate among the 42 patients was about 80%, including 68% patients with very good partial response or better, comparable to the overall cohort of patients. In addition, the 25 patients who went on the maintenance therapy, they tolerated the maintenance very well. No patients discontinued therapy while on the maintenance. Most of the side effects that we noticed with this combination occurred during the induction phase, with very few, if any, side effects that came for the first time during the maintenance phase. The common toxicities that we saw with the combination were hematologic, so neutropenia, thrombocytopenia, and anemia. The non-hematological toxicities we saw were mostly fatigue and GI disturbances. All the toxicities were very easily managed. Peripheral neuropathy was not common side effect that we saw in the study. In fact, very few patients, if any, developed a grade 3 peripheral neuropathy. Especially in the maintenance phase, nobody developed a new onset peripheral neuropathy during the single agent Ixazomib maintenance phase. The progression-free survival for the overall cohort was about 36 months, and specifically looking at the 42 patients who did not go to stem cell transplant, the progression-free survival was 29 months. About 82% of these patients were alive 4 years from the start of therapy. So overall, the combination was very well tolerated, quite efficacious, and provides the opportunity to use an all-oral induction regimen for newly diagnosed myeloma.